Hi, Mike Gibson coming to you live from SCAI 2015, and I'm joined by Peter Duffy. Peter, you're the SCAI Advocacy Committee Chair.
Yes, sir.
And of course, joined by Jim Blankenship, our incoming 2015 to 2016 President. Talking about advocacy today, a couple victories last year with the SGR repeal and some of the specialty designation for interventional cardiology on the part of CMS.
Right. Appreciate that, Dr. Gibson. Really been an exciting year for us in advocacy. One of the biggest victories we had is the SGR repeal. We've been pushing for that for almost 20 years, actually since it was put into start. It was a process that was laborious for us because each year we'd have to go to Capitol Hill, talk with staffers and representatives, all of whom agreed that it was an ill-conceived plan, but nobody knew really how to repeal it there. So we always had that 20 to 21% pay cut looming over our heads each year. Each year we were successful in getting it repealed, but it was an awful lot of effort to do that on everybody's part, and so thankfully now it's been pulled off the table. What we're seeing now is a 0.5% increase in payments to physicians as part of the payment plan there, and also looking more at how quality measures will be brought into play for payment in the future there. So that's our next step there, is to work with them on that.
You're going to get paid for quality, not quantity, but it's very vague what quality is going to be, isn't it?
Right, and that's one of the issues we're going to try to address right now. We think that they're going to use metrics from the National Quality Forum, and we hope to be able to work with the NQF to be able to see what those metrics are that are meaningful for patients, because we really do support the idea of being paid for quality. We just want to make sure that we're on the right track there and that we're not misguided by some metrics that may not be relevant to our practices.
And public reporting has some unintended consequences sometimes. I mean, even if you risk adjust, there are some circumstances where you have higher mortality with high-risk patients, and doctors stop doing those cases sometimes, and the mortality in some states, like in Massachusetts and New York, has actually gone up as a result of public reporting.
Yeah, that's an excellent point, and even people who are experts in that field will agree that they really are not where they need to be in terms of risk adjustment, and we think until we get a better definition of that risk adjustment, that it's going to be hard for us to be able to say that that's 100% of the quality measure should be based on that.
And even in California here, right here in this state, there are some issues related to that?
Yeah, absolutely. There was a bill put forth that would have had public reporting of 30-day mortality by cardiologists who are performing interventional procedures similar to what's done for the surgeons. But the problem was the risk adjustment methods weren't clear, and we were concerned that people would be risk averse and not do high-risk patients. Clearly the patients would benefit the most from those types of procedures, and in their effort to improve quality, they would actually hurt quality of care. So fortunately, that bill was not brought up before the legislature this year.
Right. What about some of the other ongoing issues that you're dealing with in terms of advocacy? Yes, Jim.
Well, let me point out that we did get the specialty designation by CMS, which is a big win.
Yeah.
Another thing we've been advocating for a full 10 years, and so that has finally come to fruition.
How does that impact us, getting that designation? It
impacts us in several ways. One is that we do get a delegate to the American Medical Association House of Delegates, and in fact we're using that power to Dr. Duffy designed a resolution to introduce into the next AMA meeting. And so that gives us the voice there. It also gives us independent voices with the CPT editorial panel and the AMA Relative Value Update Committee. And probably even more importantly, it values the services that interventional cardiologists bring. Up until now, if you did a interventional cardiology consult to one of our cardiology colleagues, we would not get separate recognition of it or payment for it. Now, as being recognized as a separate specialty, when one of our cardiology colleagues brings us a consult, asks us to review films and look at the appropriateness of a procedure, now we can actually get recognition as having provided a valuable and separate service for that.
Yeah. And speaking of CPT codes, anything going on in terms of new codes?
Well, we have several wins there. We've gotten valuation for TAVR, that was 1 to 2 years ago, and done very well with that, and more recently with the MITRA clip. So we've gotten codes and valuation for those, and we're of course going to be working on new procedures like left atrial appendage occlusion. So those will be coming down the road in the next 1 to 2 years. That means getting a separate code for it and getting appropriate valuation for those services when we provide those procedures.
Yeah. And let me add on to Jim's comments too on the specialty designation and why that's important, because as we talked about quality metrics before and how we're going to be judged on quality, one of the issues has been that we would be judged against general cardiologists and invasive non-interventional cardiologists, looking at the patient types that they treat, seeing them as different from the patient types that we treat in many cases, yet we'd all be lumped together with respect to the cost of the hospitalization, length of stay for the hospitalization, morbidity, mortality for a defined time period. And really, they are in many ways different types of patients than the ones we take care of. So our concern was that if you just lumped everything together like that and then compared us to that, it may or may not be a fair comparison. So now with the specialty designation, we can say, well, these are the types of patients we as a group take care of, and we think it is fair to start that comparison going in that way. I might mention too, for that specialty designation, it is something you have to request from CMS. It is a self-designation, so you can request through CMS to be designated as an interventional cardiologist.
Interesting. What's going on in terms of appropriate use criteria?
Yeah, so appropriate use criteria is another challenge for us there. I'll give you a good example of where appropriate use criteria is being inappropriately used, and that's in the state of New York. They announced, the state of New York Medicaid program announced in the summer of 2013 that they were going to look at a take-back for any cases that were performed after July 1st of that year that were deemed to be inappropriate under the old criteria and rarely appropriate now under the new criteria. And that was going to be with really no review process at all and no real formal way to appeal. So what our advocacy committee did, thanks to Hari Naidu and Dimitri Feldman, who were strong advocates for us, both of whom were interventionalists in New York, went to Albany and met with the staffers there and were able to convince them that, first of all, that program should be put on hold. The second is that a formal appeal process should be put in place, and that appeal process should involve an interventional cardiologist, and no take-back would occur until the final appeal process was through. So they have new medical directors now for that program. We think they're going to be following through on those agreements that were made previously, and we're very optimistic in that regard. But that's typical of what we see there, because we put out a document that says care is inappropriate. Anybody who looks at that just says, okay, well, we're not paying for something that's inappropriate.
What did we expect?
Yeah, exactly. And our concern really was more not just New York Medicaid, which is a small number of people that might be involved, there are patients that might be involved, but a potential domino effect there.
Right.
So, you know, if Medicare saw that Medicaid was doing it, you know, why isn't Medicare doing it? And then the other payers would do it, and we thought that that could just explode. So we really think it's important anywhere in the country that we see that happening. We need to be have boots on the ground there and explain that there are cases that it really is appropriate, even though the terminology may not suggest so.
And even, I think one of the recent articles showed that even if it's not deemed to be appropriate by AUC criteria, about a third of patients still had significant obstructive disease on the cath. 9% had left main disease, even though the cath was not deemed to be appropriate. So we might miss a lot of disease if we only did those, quote, appropriate cases. What's going on in some states like Oregon with respect to, you know, saying that PCI is not appropriate and CABG is appropriate as well?
Yeah, so Oregon came out with an interesting document where they had reviewed, their healthcare task force had reviewed the literature and came to the conclusion that PCI should not be performed on any patient that's over 75, that bypass surgery or medical management was clearly superior, and also that for anybody with multivessel disease, PCI would be inappropriate, that bypass surgery was superior. We fortunately had strong advocates on the ground in Oregon for us, Dr. Ed Toggart specifically, looking at those types of issues, Arthur Lee and a few others, looking at those issues. They're going before the board and showing them that their data was flawed and that they really need to rethink that. So at least at this point, that's been rescinded. But these are the types of issues that are out there. There are some good organizations, payers that really are looking carefully at what it is that we do, and they end up sometimes misinterpreting really what we've even said, and we have to be there as the advocacy committee to be able to educate them. That's really what we see our role as.
So Jim, since January, we've had a few hundred you know, techs join SCAI. What are we doing to help advocate for them?
Well, you're exactly correct. Starting on January 1st, we began to introduce our induct our first cardiovascular professional members, and we're welcoming them with open arms. So we've already had several hundred join, and we anticipate that many hundreds more will join. And so as these become full members of SCAI, then their advocacy issues become our advocacy issues. One of the biggest ones that they in fact have struggled with for 10 or 20 years has been the issue of scope of practice. And there's questions of, particularly for RCIS, Registered Cardiovascular Invasive Professionals, what can they do? And in several states and at various times, they've had trouble maintaining their scope of practice. In other words, they've been almost pushed out of cath labs. And so this issue keeps recurring, and I think that's going to be one of the big ones that we need to learn more about and advocate for our colleagues who are the technologists and the administrators who work in our cath labs. We'll find out what other advocacy issues they have. We have a first meeting of our Cardiovascular Professional Committee tomorrow morning, and we'll find out about exactly what their issues are and start working on them too.
Yeah, this is really exciting because this really brings the heart team concept together, which is what we've talked about for many years, and bring all of us under that one umbrella there to be able to work together to advocate and understand each other's issues. I think really makes us a stronger society and is really much better for our patients.
Well, this, go ahead.
One other point to bring out is that, as Dr. Duffy has mentioned, as state issues come up, it's very important that our society have advocates in those states that can take it at a state level. And of course, you have to be a resident of the state to be effective advocating at a state level. So we really need members in every state that can deal with these issues as they come up, and it's guaranteed that there will be more issues coming up in every state. So I would encourage anyone, member of SCAI, who is interested in doing this kind of work to contact Dr. Duffy. Raise your hand and make yourself known to Dr. Duffy, because we'll be needing your help in other states as these issues arise.
And the key too is making sure we know about it, because frankly it was a year before we knew that that was a Medicaid policy, and we only found out about it through a member who asked a question. Wow. And many members knew about it for a year, and we weren't able to do anything about it for that long a period of time. So as soon as anybody finds out that there's an issue that they're facing there, we really appreciate it if they contact us.
Well, so often physicians feel, I'm just one guy, I'm helpless, but that's why SCAI is here. And if they do tell you about this, you'll be there to help them, right?
Absolutely.
I mean, they're not going to take this issue on alone. SCAI and its advocacy group will be behind them to help fight these battles.
Dr. Duffy and his committee have been enormously effective in advocating at many different levels on these issues. And so I think that gives me a great sense of confidence that as these things come up, we can deal with them and effectively advocate for ourselves and, more importantly, for our patients.
Well, it sounds like a full-time job. And I know all of us thank you and appreciate all the hard work.
It's a labor of love. This is what we do.
If
we can't advocate for our patients and we can't advocate for our colleagues there, then I think we're not fulfilling our role as interventional cardiologists.
Well said. Well said. Congratulations on all the success this past year. Thank you for advocating for us. And thanks to all of you out there for joining us live from SCAI 2015.